This video is about surgical safety checklist by WHO and how to implement it correctly. So WHO's safety checklist is a famous safety checklist in the field of medicine. Anyone who has undergone a surgery recently or who has been in a surgical scenario knows that it's a mandatory part in each and every surgery. This was actually introduced by the WHO around 2008, 2009, I suppose. Yeah, and it WHO says the introduction of this is the aim of introduction of this is to increase the communication and teamwork among the medical personnel who are involved in the patient care in a surgical scenario, and by that they have shown by studies that there has been better patient outcomes just by implementing this checklist. We'll see the checklist has three parts actually. First part, second part, and third part, as you can see, and we'll see each and every part in detail and how to implement each and every part in detail later. But first, we'll see, just go through quickly. The first part is the first check should be done before induction of anesthesia, and it is also called the sign-in check. The second part should be done after induction of anesthesia but before the skin incision by the surgeon. This is also called the timeout check. The third part is called before patient leaves the operating room check, also called the timeout check. So there are three parts. And who should do this check list checking business? Who should be doing? What WHO recommends is you, any clinician who is involved in the patient care can be allocated to do the safety checklist, but in a operation theater it's usually done by a nursing staff actually. But what they stress on is actually whoever it can be, but a single person should be allocated for a single surgery to do all three parts of the checklist. So there should be one person who's doing all three parts for a particular surgery. So that's what they recommend, right? Okay, so whether we'll go into details of each and every part and how to implement them correctly. All right, the first part, before induction of anesthesia or sign-in check. So this should be done with the patient, the anesthetist, and the nurse who is going to do the checklist. So three people should be present at the time of the check, and the surgeon who is going to operate, his presence or her presence is not mandatory according to WHO. But if he or she can be present, it's actually a good thing. That's what they say. But the presence of surgeon during this check is not mandatory, but only favorable. Okay, so the first part is all about checking the patient's identity and the surgery and consent. So this is between the nurse and the nurse, or I'll just call the person who's going to check the nurse. So it is between the nurse and the patient. So the nurse will first ask a question like, can you please confirm your name and date of birth? So the patient will say, I'm so and so, and my date of birth is 1957 December 27th. So the nurse will cross check it with the BHT or the patient records. Then she will ask, so what is the procedure that you are going to undergo? And the nurse, um, patient might say, I'm going to undergo a hernia repair. Then she might ask, which side? Patient might say, left side. Again, cross-checking with the patient records. And finally, she will go to the consent sheet and ask, have you signed the informed written consent form? The patient might say yes, and she will show the signature. So this is your signature. The patient will say yes, and if everything is okay, the first part is completed and you can tick the box just in front of yes. So that is the first part of the sign-in check. The second part is the question: is the site marked? So the nurse reads it loud. Is the site marked? Actually, during this time is when the surgeon's presence is favorable, because each and every surgeon has their own style of marking the sites and they need it done in their way. So if he's there, he can check the site markings and say yes. Or for surgeries like laparoscopic cholecystectomy, it's not applicable, so we can say just not applicable. If the surgeon is not there, the nurse can just check with the patient and see the site, and if it's marked, she can say yes. If the site is not marked, there should be the responsible person. There should be a responsible person who should be called, and the site should be marked. The third question is the anesthesia machine and medication check complete? So this the nurse asked from the anesthetist. To say yes or to tick this yes, the anesthetist should have checked the necessary equipment, the anesthesia machine, oxygen, supplementary oxygen, airway adjuncts, laryngoscope, emergency drugs, and all the drugs that are necessary for the patient induction, maintenance, analgesia, everything. So if everything is done, the anesthetist might say yes. So with that, the box can be checked. The next question is the pulse oximeter on the patient and functioning? So this stresses the importance of using a pulse oximeter during any kind of surgery, because pulse oximeter is a mandatory monitoring equipment in all forms of surgery. Even for local anesthesia, a pulse oximeter is actually advised in many guidelines. So the answer is, the nursing officer should check whether the pulse oximeter is on the patient's hand and it's working, giving correct work form and readings. So that's the fourth part. Then comes the last part of the first check. It has three questions. The first question is the nurse reads out any known allergies. So the anesthetist might have done the pre-medication. So the anesthetist might say the patient is allergic to amoxicillin. So the nurse, the patient, and if the surgeon is also present, he will also get the information. So the information is shared among all the personnel who are going to care for the patient. At this time, if the surgeon knows something else, such as if the surgeon knows the patient is allergic to povidone iodine or chlorhexidine, he might also say the patient is allergic to chlorhexidine as well. So the anesthetist or the nurse might not know that information, but the surgeon knows the information and he shares information, and now all of them are aware of the information. So it just a better thing for the patient who is going to undergo the surgery. So if a peripheral nerve block or a regional block should be given, the anesthetist, if he or she had not known about the chlorhexidine allergy, he or she might have used the chlorhexidine on the patient. So now she knows because of the information that she got from the surgeon. So the patient safety is improved with this, right? Okay. So the second question on this part is there a difficult airway or aspiration risk? So this question is directed towards the anesthetist, and the anesthetist always does a airway assessment prior to the surgery. So according to his or her assessment, he or she might say yes or no. But at this point, if the answer is going to say yes, the answer must also confirm that uh, he or she has made necessary arrangements uh, to tackle the problem, and and had called for help, informed their seniors, and made the necessary airway equipment ready and everything. So in that case, the yes box can be checked. But if the airway equipment, emergency airway trolley, everything is not ready, it should be made ready, and then only it can be checked yes. And if there's no difficult airway or aspiration is expected, then the box no can be checked. The last question on the first check is about blood loss. So the nursing officer reads out loud risk of blood loss. The risk of blood loss is considered yes if the blood loss is expected to be more than 500 milliliters in an adult or 7 milliliters per kg in a children, according to the WHO safety checklist. So if the anesthetist, this is also directed towards the anesthetist, not towards the surgeon, but the same question will come in the second part, and that is directed towards the surgeon. So at this point, the anesthetist should answer this question, because they are the one who is going to handle the fluid management intraoperatively, and the blood transfusion and everything is handled by the anesthetist. So if there are no risks, they will just say no. If there is yes, if there is a risk, they will say yes, and at the same time they'll say yes, there's a risk, we have inserted two large blue IV cannulae, we have informed the blood bank, and we have sent the blood for grouping and TT, and at the same time we have we have arranged for point of care testing, such as thromboelastometry and everything. So and we have planned to insert intra-arterial blood pressure monitoring and everything. So with that, the yes box can be checked. So this is the sign-in check, or the first part of the WHO checklist, and this is how it is implemented. So just let's now look at the second part.